Okay, so we just talked about how to classify patients with chest pain as low risk. Now let's talk about what to do with them. At the end of the last video, we talked about sending a patient home after getting one troponin, and I'd like to introduce the concept here, opening the door on cardiac testing. So if you open the discussion on whether this patient is suffering from a possible acute coronary syndrome, that is, if you open the door, then you better be willing to close it. Now, I'm not saying that every patient needs a cardiac workup, and that's obviously not true. Not all of them do. But if you think that they do, take the workup to its ultimate conclusion, which for us means a stress test. So remember that the spectrum of acute coronary syndromes runs from a myocardial infarction down to unstable angina. And when you said troponins and EKGs, you're just looking for this. You have not addressed this. What is unstable angina? It's a blood vessel with a flow-limiting plaque, which is getting bigger and bigger. And the ultimate point of this is when the flow reaches some critical level or even gets completely obstructed, is no flow, leading to an MI. So another way to say that is an unstable angina is an MI waiting to happen. Do you want to send those patients home? No, of course not. So we want to try to determine if our patient is suffering from these flow-limiting occlusions here before the MI happens. And how do we do that? Through some sort of stress testing. We want to get enough blood flow pumping through here and enough demand on the opposite end of here that we will see EKG changes or wall motion abnormalities or something in a controlled setting in the hospital while this patient is exercising. And we'll use that as an indicator to do any further intervention such as a cath. So maybe when this guy is just walking around, this one arrow worth of blood flow is enough for his heart, and that's fine. But when he's exercising, he needs more, and this second arrow can't get through. So now he gets chest pain when he's exercising, and now he gets ischemic changes on his EKG, or he has some wall motion abnormalities on his echo. So this is what we're looking for with our stress testing. We're going to try to provoke these changes. So we call this provocative testing. So what are the different kind of provocative testing modalities we have available? The one used in most places is exercise treadmill testing. And if a patient can't exercise, we can also fake the exercise by giving them a chemical stress test, something that speeds up their heart. Alternatively, we can do some sort of imaging, and this includes echocardiograms, myocardial perfusion imaging, and coronary artery imaging, which can be done by CT or MRI. So what's an exercise treadmill test? Obviously, as the name suggests, you exercise on a treadmill, and then we watch your heart using usually EKG monitoring to look for any signs of ischemia. So to be able to get this, you obviously have to be able to exercise, have a near normal EKG with changes that wouldn't mask any signs of ischemia, and obviously not have any arrhythmias and to be hemodynamically stable. And you don't want anyone who's having an MI to do this because you'd be making it worse, so normal cardiac markers. And then what you do is you follow the Bruce protocol, which just tells you how long you go at one incline, then another incline, then another incline until you finally stress the patient enough to get to about 85% of their maximal heart rate. There's also a modified Bruce protocol which does this at a slower increase for people who are a little bit deconditioned. So you do this until the patient either finishes the test, gets signs of ischemia on their EKG, they drop their blood pressure, or they start developing chest pain. So a positive stress test would be one in which there is more than a millimeter of ST depression on their EKG, so they're having EKG changes consistent with ischemia. A negative one is one in which they get up to 85% of their maximum heart rate without any signs of ischemia. And then a non-diagnostic one is one where maybe they can't get up to 85% of their maximum heart rate before they have to stop, but there is no evidence of ischemia on the EKG. And the negative predictive value for exercise treadmill test is anywhere from 89 to 100%, depending on the study you look at. And there are other scoring systems which try to help increase this, such as the Duke treadmill score. And you could find calculators for this online. Here's one of these calculators for a Duke treadmill score. And you could say, look, how long was the patient able to do their treadmill test? Were they able to get to 7 minutes? How big were these ST depressions that you saw, 2 millimeters? And did they get any chest pain during this? thing, and then it gives you your 5-year mortality or probability of severe coronary heart disease, and probably significant. And here for this one, you'd say it's pretty moderate risk, and they would recommend angiography. So next, let's talk about myocardial perfusion imaging. So at Rush, what we're using is a Sestamibi Scan. And what this does is you inject this radioactive marker, and it's going to be taken up by all areas of the heart that are getting blood. So you do it when somebody is theoretically having some decreased blood flow state. So when they're having chest pain, when they're having ischemia. And the area here that's ischemic is not going to be getting blood flow. So then what you would hope to see is that everywhere else you would see this radioactive marker taken up, except in the area that is ischemic. So you inject the dye when they're having a low blood flow state, so when they're having chest pain, and then it gets taken up everywhere, and you can image them later. And when you image them, you're looking for areas where there's no uptake. It's got a sensitivity of about 87% and a specificity of about 73%. And you could get some ejection fraction and wall motion abnormality information from this imaging as well. Now here's the thing, this does involve radiation. And if this area of ischemia is pretty small, you might miss it. So what about echocardiography? Well, you can do this two ways. You could do it rest, and you could do it with stress. Now, rest echocardiography looks for wall motion abnormalities. So if all areas of the heart are moving except for one area, that's a wall motion abnormality, and that's a pretty good indicator that someone's had an MI in that area. And it's got a negative predictive value of 97% and a positive predictive value of 24. So again, this is looking for areas of a heart that is already damaged by infarction, and it's pretty good at finding that. But in order to see it, you have to have about 20% of the wall to be affected, 20% or more of the thickness of the myocardium has to be affected in order to see it on the echo. Now this can be done as a stress as well. So if you throw a little dobutamine in there and just make the heart pump a little bit faster, you get a dobutamine stress echo. And so the negative predictive value at 6 months for any adverse effects was 96%. That's pretty good. So what else we got? We got coronary artery imaging. And so one way to do this is to look for calcium in the coronary arteries. And then you can calculate a coronary calcium score. And in some studies, this has had a negative predictive value approaching 100% for adverse effects. But I see two problems with this. First of all, this is a lot of radiation because you're looking at it using CT, and not all plaques have calcium in it. Sure, as we get older, we're more likely to have calcium building up in there, but maybe for younger patients it's not as good. Alternatively, you could shoot IV dye through these coronary arteries, and the newer resolution scanners are good enough that they could look at this level of detail necessary and find any areas where there might be some narrowing. So now we got a CT coronary angiogram. This is even more radiation than this, though. It's the equivalent of about 250 to 500 chest x-rays. And the effective dose to breast and lung tissues is even 3 times higher than that. And of course, you can't give it to patients who have an IV dye allergy. And I think it's important not to underestimate the amount of danger that this radiation will play. Some are predicting that anywhere from 1/3 to 2/3 of the cancers we're going to see in the future are going to be due to the CTs that we're using today. Who knows if that's true or not, but I think it's at least worth entertaining that idea. The other allure of doing a CT was that it allows you to look at other things. So with the same CT, you could look for a pulmonary embolus and thoracic aortic dissection. And together this was called the triple rule-out. And people had high hopes for this. They figured I could just do one CAT scan. I could look at the coronary arteries and rule out acute coronary syndrome. I could look for a clot in the pulmonary vasculature and rule out a PE. And I can also look for thoracic aortic dissection. However, this didn't play out in reality because the way these CTs need to be protocoled, it's different. You can't do the same CT for PE and look at the coronary arteries. And the CT that looks for coronary arteries is not good enough to look for thoracic aortic dissections. So this triple rule-out ended up just being a wishful fantasy. We talked about, well, we at least mentioned MRI, but there's not enough data out there really to make any claims for use of MRI. And then the last thing I wanted to talk about is what is commonly called as the warranty period or expiration date of a normal CPU or observation unit testing. So if someone had a normal stress 2 years ago. Is that still valid today? Or normal stress 6 months ago, is that still valid? And at 2 years out, they looked at a normal stress MPI. The overall cardiac event rate was about 1.1%. And that number jumped up to 1.4 to 1.8% in the highest risk patients. And this article also mentions that coronary arteries occlude at about 3 to 6% per year. Their occlusion increase, the diameter decreases. And this rate is higher in patients who already have coronary artery disease. But take this with a grain of salt, because remember that any plaque can rupture at any point and then serve as a nidus for clot formation. So the take home for me for this is evaluate each patient's visit individually. Judge it by its own merits. Now if they had a recent stress test, that does give you some ammunition to decrease the risk, but it's not perfect. Alright, that's it. Thanks.